Bismillahirrahmanirrahim. So now we are going to start with the allergy and immunology. So the allergy and immunology, humoral immunodeficiency syndromes, the condition CD40 ligand deficiency or hyper IgM syndrome, the cell counts and antibodies, B cell count and antibodies, different antibodies have different values in different syndromes. So let's talk about them. So in hyper IgM syndrome, the B cell count will be normal, IgG will be low, IgA will be low, IgM will be high because it is hyper IgM syndrome, and IgE will be low. So basically, the concept in hyper IgM syndrome is that whenever there is, you know, whenever an antigen comes to the body and the B cells detect, then there is a concept of, I don't remember the name of the concept. So basically, the class switching. Yeah. So there is the concept of class switching. Like the B cells will communicate with the T cells, and there will be the CD40 ligand on the T cells that will be binding the CD40 receptors on the B cells, and resultantly due to the CD40 ligand to CD40 interaction, there is a class switching. Normally the B cells are trained to produce IgM and IgD, right? But when the class switching occurs, so different antibodies like IgG, A, M, and E can be produced depending upon the stimulus. But if there is a lack of the CD40 to CD40 ligand deficiency, like CD40 ligand in itself is not present, so that will result in hyper IgM syndrome. So only IgM will be high and all the antibodies will be low with a normal B cell count. Common variable immunodeficiency, the B cell count is normal, but all the antibodies are decreased. In Job syndrome, which is hyper IgE syndrome, as the name indicates, the IgE level will be high. There is some problem with the JAK-STAT pathway in this one, but uh, all the other things will be normal, including the B cell and the rest of the antibodies. Selective IgA deficiency, the IgA will be low, and the rest of these things will be normal in these patients who have selective IgA deficiency. The thing that you must be cautious with is while giving them blood transfusion, you must assess the IgA levels, and if the person is having selective IgA deficiency, then you must not include the IgA in the blood products. The IgA must be filtered out of them. X-linked agammaglobulinemia, it is also called as a Brutton's agammaglobulinemia. Everything is decreased because there is a deficiency in the Bruton kinase, and B cells are not matured, and that results in no B cells and no antibodies thereafter. Then there is primary humoral deficiencies. These were humoral immunodeficiency syndromes. So there is also a table about them. So primary humoral deficiencies, X-linked agammaglobulinemia. For all of them, what we are going to discuss, recurrent or severe cyanopulmonary infections with viruses and encapsulated bacteria occur. So X-linked agammaglobulinemia, there is decreased or absent B cells and decreased immunoglobulins. Common variable immunodeficiency, normal B cells and decreased immunoglobulins. If there is IgA deficiency, there will be normal B cells with decreased IgA. Hyper IgM syndrome, normal B cells, decreased IgG and A, while the IgM will be more than usual. And IgG subclass deficiency, there will be normal B cells with decreased IgG. So let's talk about Brutton's agammaglobulinemia. It is also called as X-linked agammaglobulinemia. The clinical manifestations are recurrent cyanopulmonary and gastrointestinal infections after the age of 6 months. Why after age of 6 months? Because until that age, the maternal IgG, they circulate in the fetal, not fetal, in the infant's blood. And after that, after 6 months time, when they start fading out of the scene, so the child start developing recurrent cyanopulmonary and gastrointestinal infections. Absence of lymphoid tissue on examination, in the tonsils or lymph nodes, they will not be present. Diagnosis, decreased immunoglobulins and B cells, normal T cell concentration, no response to the vaccinations. Treatment is immunoglobulin replacement therapy and prophylactic antibiotics if it is very severe, so we have to give prophylactic antibiotics as well. Recurrent cyanopulmonary and GIT infections, markedly low serum immunoglobulins and B lymphocytes. Total lymphocytes minus T lymphocytes is B lymphocytes. So there is B lymphocytes will be low, B lymphocyte count will be low, and serum immunoglobulin level will also be decreased. Underdeveloped lymphoid tissue in older children under the age of 2 years normally don't have prominent lymphoid tissue. Then absent lymphoid tissue is also seen in Bruton agammaglobulinemia. Treatment, monthly IV immunoglobulins, prophylactic antibiotics. Live vaccines are contraindicated. Other vaccines are not contraindicated, but they are unable to generate an antibody response. Okay, so monthly IV immunoglobulin, prophylactic antibiotics, and live vaccines are contraindicated. Other vaccines are not contraindicated, but they are unable to generate an antibody response. Transient hypogammaglobulinemia of infancy features decreased IgG, variable IgM, and normal IgA and B cell, B and T cell concentrations. That is called as transient hypogammaglobulinemia of infancy. Cyanopulmonary and GIT infections which are relatively mild. Immunoglobulin levels normalize after the age of 9 to 15 months. That is transient hypogammaglobulinemia of infancy. Okay. They'll normalize in the after the age of 9 to 15 months. Here you can see that common variable immunodeficiency, it is similar to the Britons, but the patients present with the less severe symptoms after adolescence. Serum immunoglobulin concentration are decreased, but the B lymphocyte levels are normal. Immunodeficiency tips. Recurrent cyanopulmonary infection mean a B cell dysfunction. If there is cyanopulmonary infections, because the cyanopulmonary infections are inhibited or protected, we get a protection from them by the IgA antibodies, which are lining our mucous membranes, and they are being produced by the plasma cells, which are basically advanced B cells. If the person is having B cell dysfunction, then we are having recurrent cyanopulmonary infections. Recurrent GIT infections with cyanopulmonary infections mean IgA dysfunction, and recurrent viral and fungal and opportunistic infections means a T cell dysfunction. Okay. Like for the cyanopulmonary infections, we have B cell as a whole. If it is specifically GIT and cyanopulmonary infections, then we say it is IgA deficiency. And if we are having recurrent viral, fungal, and opportunistic, then T cell dysfunction is there. The next thing is C1 inhibitor deficiency. It is a complement dysfunction that may result in hereditary angioedema. Pathophysiology. C1 inhibitor deficiency or dysfunction will lead to excessive bradykinin, because the C1 inhibitor also inhibits also is responsible for the breakdown of bradykinin. If that is not there, so resultantly the person is going to have excessive bradykinin levels, and that will result in hereditary angioedema. The clinical features include swelling, for example, face, extremities, and genitalia without urticaria. There will be laryngeal edema and colicky abdominal pain, vomiting, and diarrhea. Diagnosis: there will be low C4 levels and low C1 inhibitor protein or function. Management: C1 inhibitor concentrate is given. So it is autosomal dominant. Now you must remember this thing, that C1 inhibitor deficiency is autosomal dominant in nature. Recurrent edema without pruritus or urticaria will be there. This edema is because of elevated bradykinin. Edema with pruritus and urticaria along with anaphylaxis is most probably IgE mediated, not C1 inhibitor mediated. So like if it is just edema, so that is C1 inhibitor deficiency. But if it along with edema, we are having pruritus and urticaria, so that is most probably IgE mediated, not C1 inhibitor deficiency. Presentation: it can present after dental procedure, after some sort of stress, trauma. Multiple areas are involved, including the face, limbs, and genitalia, the most commonly affected. Bowel wall edema include colicky abdominal pain, vomiting, diarrhea, and laryngeal edema most severe and can cause laryngospasm and airway obstruction, which can be life-threatening as well. Diagnosis: exaggerated cleavage of C4 by C1 complex lead to depressed C4 levels, low C1 inhibitor protein, or C1 inhibitor function. So since too much of C4 is being cleaved, that will lead to decreased C4 levels, and C1 inhibitor protein itself will be deficient. Treatment is C1 inhibitor concentrate. Bradykinin antagonists like icatibant can be given, and kallikrein inhibitors like ecallantide, that can also be administered in the resistant cases. Icatibant and ecallantide, which is a kallikrein inhibitor, and this one icatibant is the bradykinin antagonist. They can be given in the resistant cases. The contraindications to rotavirus vaccine: anaphylaxis to vaccine ingredients, history of intersusception. It is very important because the rotavirus will stimulate the growth of Peyer's patches in the terminal ileum, and those Peyer's patches will act as a lead point for causing the terminal ileum to intersuscept into the cecum. Then we have history of uncontrolled malformation of GIT, for example, history of uncorrected malformation of GIT like the Macus diverticulum. I guess it is also because of this very reason. And then we have skilled, because it's a live vaccine, so the people who have severe combined immunodeficiency, we cannot give this, because A, they cannot mount an immune response to that. B, they will become very severely infected by the vaccine material itself. Rotavirus causes watery osmotic diarrhea. Vaccination of the preemie. Vaccinate according to the chronological age since birth. Only hepatitis B vaccine is administered when the patient's weight is more than 2 kg. Okay. The next thing is this thing. So here you can see the C1 esterase inhibitor. What does it normally do? C1 is converted to activated C1, right? And that activated C1 can lead to complement cascade activation. This is inhibited by the C1 esterase inhibitor. So the C1 esterase inhibitor, which it normally causes what? It normally causes it normally inhibits the conversion of C1 to activated C1, right? And then the complement cascade cannot be activated. Now, if this is decreased, there will be excessive activation of the complement system, and that can result in angioedema. Secondly, if we look at this pathway, so the C1 esterase inhibitor also inhibits the kallikrein, right? But if it is not there, the resultant in the kallikrein can cause the plasminogen to be converted into plasmin. That plasmin will help in conversion of fibrin into fibrin split products. These fibrin split products can directly stimulate the C1 to be activated and form activated C1. Also, then these activated C1 can cause angioedema. Thirdly, the kallikrein also helps conversion of kininogen to bradykinin, and that bradykinin then causes angioedema. The angiotensin converting enzyme converts the bradykinin into inactivated products. Okay, got it. And if the people have angiotensin converting enzyme deficiency, so they can develop excessive amount of bradykinin, angioedema, and on top of that, if the person is having this, so we cannot give them ACE inhibitor drugs, because those people who have C1 esterase deficiency, if they are given ACE inhibitor drugs, there will be excessive accumulation of bradykinin in their blood, and they will develop angioedema. The next thing is about the complement cascade. So it is not very important, but for the sake of completion, let's see this. Now here you can see that this is antigen, antibody, and then this is C1 complex. And as per classical pathway, this is C2 and this is C4. The classical pathway, C2 and C4 combine to form C4B, C2A complex. Actually, you're not supposed to do that. Just remember that there is a classical pathway, and then we have an alternative pathway, and both of them merge together at the MAC, which is membrane attack complex, that is C5, B6, 7, 8, and 9, and they drill the holes into the cell. That is together they're called C9. And when they drill the holes into the cell, the water will enter the cells, and the cells will swell, and they will burst. Okay. So what is hereditary angioedema? Hereditary angioedema, as per pathophysiology, it is an autosomal dominant de novo mutation, C1 inhibitor deficiency or dysfunction. There will be excessive bradykinin that will lead to fluid extravasation into the skin and mucosal tissue, for example, bowel wall and upper airway. The clinical features are cutaneous swelling, for example, of the face, extremities, and genitalia. No urticaria or pruritus is present, and no identifiable trigger like ACE inhibitors or NSAID is present. Colicky abdominal pain, vomiting, and diarrhea. Laryngospasm and airway obstruction from the laryngeal edema is also can also occur. So colicky abdominal pain, vomiting, and diarrhea. Laryngospasm, airway obstruction from the laryngeal edema can also occur. How do we diagnose this? There will be a decreased C4 level and decreased C1 inhibitor protein or function, and there are recurrent episodes of non-pitting edema. Acute management: C1 inhibitor concentrate, bradykinin antagonist like ecatibant, and kallikrein inhibitor like ecallantide. Chronic granulomatous disease, which is caused by NADPH oxidase deficiency. So this one is X-linked recessive, and that is why it is common in boys. Look for recurrent infections in the following by catalase positive organisms. Skin and soft tissue infections like recurrent abscesses will be there, and pulmonary system pneumonia or empyema will also be present. How do we diagnose that? We test for the neutrophil function by the dihydrorhodamine 1, 2, 3. What does that mean? And nitroglutazoline test. Gram stain shows phagocytic cells filled with the bacteria. Leukocyte, platelet, and B and T cell concentrations are normal in the chronic granulomatous disease. Treatment: prophylaxis is with a TMP and SMX, which covers the catalase positive bacteria, and itraconazole, which covers the catalase positive fungi like Aspergillus. Interferon gamma injections can be given in very severe cases. In chronic granulomatous disease, The clinical feature, majority of the cases X-linked recessive, recurrent pulmonary and cutaneous infections, catalase positive pathogens like Staphylococcus aureus, Serratia, Burkholderia, and Aspergillus. They used to be mnemonic like SNAPS, SNAPS. S was for Serratia. Then this is Neisseria, right? And Aspergillus, Pseudomonas, and Staph aureus. So I guess this was mnemonic. Diagnosis is neutrophilic function test. We do that by dihydrorhodamine 1,2,3 test and nitroglutatazolium test. Severe combined immunodeficiency. The main problem is with the T cell development. Gene defect causes its failure. B cell dysfunction is not primary, it is due to absent T cells. That is why in the SCID, when we perform the X-ray of the chest, head and neck, so the thymic shadow is absent in these children. Hence, the bigger picture shows absence of T cell and dysfunctional B cells. Okay. B cell dysfunction is secondary to the absence of T cells because B cells require T cells for their activation as well. So there is absent T cells and dysfunctional B cells. Inheritance pattern is X-linked recessive. Now there are two types of inheritance patterns. If we are talking about X-linked recessive, so the problem is interleukin 2 receptor gamma deficiency. Yeah, and if it is autosomal recessive inheritance, so adenosine D minus deficiency will be there. Now interleukin 2 receptor is basically interleukin 2 receptor, like on all the B and T cells we have an interleukin 2 receptor. That receptor definitely binds to the interleukin 2, and when it binds to that, it helps in the proliferation of the cells, right? If it is absent, so cells cannot proliferate. Secondly, the problem is not in the whole receptor. If there is a gamma chain of the receptor which is defective. So in X-linked recessive disorder, that is X-linked recessive SCID, the problem is with the interleukin. I'm sorry, this one. The problem is with the interleukin 2 receptor gamma chain, and in the autosomal recessive variant, the problem is that suppose these are the cells. So adenosine D minus normally detoxifies the adenosine, and if it is not there, so excessive amount of adenosine starts accumulating into the cells, and that is also cytotoxic, so that results in the cell death. Presentation: there will be chronic diarrhea, failure to thrive, absence of lymphoid tissue, lymphopenia, and hypogammaglobulinemia. The clinical features include recurrent viral, fungal, and opportunistic infection, failure to thrive, and chronic diarrhea. Treatment is stem cell transplantation. Severe combined immunodeficiency, the etiology, gene defect leading to the failure of T cell development, B cell dysfunction due to absent T cells, inheritance is X-linked recessive and autosomal recessive. The clinical features are recurrent, severe viral, fungal, or opportunistic, that is pneumocystic infections. There will be failure to thrive and chronic diarrhea will be present. Treatment is stem cell transplantation, but even this has not shown very promising results. The next thing is about selective IgA deficiency. Most common primary immunodeficiency. This is an important point, that the most common immunodeficiency is IgA deficiency, selective IgA deficiency. You must look for recurrent sinopulmonary and GIT infections. Autoimmune disease, for example, celiac disease and diseases and SLE can also be associated with this. Atopy, like asthma and eczema, can be present. Anaphylaxis due to the blood transfusion due to IgE antibodies against the IgA products which are present in the donor blood, right? Because our body is not used to seeing IgA in the body, while the donor blood will have IgA. So if that IgA enters our body, so the body of an IgA deficient person will realize that IgA is a foreign body, so it will start producing an anaphylactic reaction by activation of IgE antibodies against the IgA, and that is how the anaphylaxis results if we have not screened the patients beforehand. Diagnosis: low or absent IgA, normal IgG, IgM, and B cells. Treatment: supportive care and medical alert bracelets or transfusion reactions for the severe deficiency. So these people must have some tattoo or some medical bracelets which must tell that they are having IgA deficiency. Why do the people wear those bracelets? Because, for example, there can be emergency anytime, anywhere. If the person is having some road traffic accident, or the person has some, the person just have a syncope, and we have to resuscitate the patient in a surgical way, and we start giving him O positive or O negative blood in bulk quantity. So that can be a catastrophe for the patient instead of being life saving if the person is severely IgA deficient. So they must wear those bracelets. Common variable immunodeficiency. The age of presentation, is around puberty and adulthood. So it is very similar to SCID in presentation, but the problem is that it presents late. So it presents around puberty, and the adulthood age 20 to 40, it is more common. B cell differentiation problem. So normal B cells and decreased immunoglobulins. B cell differentiation problem. So that there are normal B cells and immunoglobulins are not being produced because the B cells are not differentiating properly. Presentation. Recurrent sinopulmonary and GIT infections. It's an autoimmune disease. Chronic lung disease like bronchiectasis can be present. GIT disorders including the chronic diarrhea and inflammatory bowel disease like condition. Diagnosis is decreased immunoglobulins, normal B cells, and no response to the vaccines. Management is by IV immunoglobulin infusion. And CVID patients have increased risk of autoimmune disease and certain malignancies regardless of treatment. So let's see this table about CVID first. So over here, common variable immunodeficiency pathophysiology, abnormal differentiation of B cells into the plasma cells. Yep. So abnormal differentiation of the B cells into the plasma cells is happening. Then that will result in the decreased immunoglobulin production. The clinical manifestation is symptoms onset classically at age 20 to 40, as early as the puberty. Recurrent respiratory infection, for example, pneumonia, sinusitis, and otitis. Recurrent GI infections like Salmonella, Campylobacter, and Giardia. Chronic disease will show autoimmune. Chronic diseases like autoimmune diseases like rheumatoid arthritis and thyroid disease will be present. Pulmonary manifestations like bronchiectasis and fibrosis will be there. And GI infections like chronic diarrhea, inflammatory bowel disease like conditions will also be present. Diagnosis. There will be decreased IgG, decreased IgA and IgM, no response to vaccination. Management. Immunoglobulin replacement therapy is the management of choice for the CVID. Then the next topic is about, just give me a second. Yep. So it is primary immunodeficiency syndromes. Again, we are having a summary of that. I think we have seen this table before. So in this table, they are telling us about the primary immunodeficiency syndromes. It's a new classification. So B cell disorders, age of onset is variable like 4 to 6 months. Key feature is encapsulated bacteria and recurrent sinopulmonary infection. Also, enterovirus can cause infection in the B cell disorders. Enterovirus can cause infection only in the Brutton's A gamma globulinemia or X-linked A gamma globulinemia. Lab findings include decreased immunoglobulin and vaccine response, X-linked A gamma globulinemia, and common variable immunodeficiency. So for X-linked A gamma globulinemia, the age is after the maternal antibody wanes, that is 6 months. Male and family history. So males are affected more, and these people also have a family history. Common variable immunodeficiency around the puberty or 20 to 40 years. T cell and combined B and T cell disorders. Presentation is early, that is less than 4 to 6 months. Viral, bacterial, and fungal infections like Candida and Pneumocystis, and these children have a failure to thrive. They include DiGeorge syndrome, which is the T cell disorder, SCID, which is B and T, Prescott-Eldridge syndrome, which is B and T, and ataxia telangiectasia is also B and T disorder. Decreased leukocytes, and with or without IgG and vaccine response. Okay. Then we have phagocyte disorders. They present in early childhood. Skin and soft tissue infections will be more prominent. Fungal infections will be there, and catalase positive organism will cause this only in the chronic granulomatous disease, and these organisms are Staphylococcus aureus, Burkholderia, Serratia, Aspergillus, and Nocardia. Normal IgG, impaired oxidative burst, and that is also seen like these two things, catalase positive organism infection and oxidative burst are seen only in the chronic granulomatous disease. There is another disorder that is called as LAD. In this, the child or patient has apparent neutrophilia, but the neutrophils cannot migrate to the site of infection. Then we have complement disorders. The age of onset is variable. Neisseria infections and autoimmune disease can result in these children. And on laboratory, we find decreased CH50 and normal leukocyte and immunoglobulins. C1q deficiency, terminal complement C5 to C9 deficiency. For that, we give eculizumab can increase the risk of complement deficiency infection. Okay, I'm sorry. If we give eculizumab, which is a complement inhibitor, if we give this to these patients with the complement disorders, so that can increase the risk of complement deficiency infections. So we have seen this table before, right? I don't think that we need to revise it again. Yeah. So moving forward, we have leukocyte adhesion deficiency. Recurrent skin and mucosal bacterial infections like omphalitis and periodontitis will be seen in the children who have leukocyte adhesion deficiency. So there will be zero purulence, which means no pus, lack of neutrophils at the inflammation site. The problem is that there is a defect in CD18 coating index. You will see the table. So in these situations, because of lack of CD18, if you remember the steps of inflammation, so in that the migration of neutrophils require CD18, right? If that is not present, so resultantly the neutrophils won't be able to migrate to the site of infection, and that will result in poor wound healing, delayed cord suppression more than 21 days, that is also called as omphalitis, marked peripheral leukocytes with neutrophilia. Biopsy of the infected tissue shows lack of neutrophils. Culture shows mostly Staph aureus and gram-negative bacilli. Not seen in mild integrin defects, so don't rely on this. What? Biopsy? What test? I don't know. So it is not seen in the mild integrin defects, so we are not supposed to rely on this. Biopsy or culture or what? I don't know. I think they're talking about something. So leukocyte adhesion deficiency. Pathophysiology: defect in CD18 containing integrins, impaired leukocyte adhesions, and endothelial transmigration. The clinical feature is skin and mucosal infections like cellulitis and periodontitis without pus formation, impaired wound healing, delayed umbilical cord separation, aged more than 3 weeks. For the laboratory findings, we have leukocytosis and neutrophilia. Okay. The next thing is about hyper IgE syndrome. So the hyper IgE syndrome, also called as Job syndrome, inheritance pattern is autosomal dominant. Again, another disorder which is autosomal dominant. Before that, we talked about C1 esterase inhibitor deficiency, right? So this is a hyper IgE syndrome. It is an autosomal dominant disorder. Presentation is with the recurrent skin abscess, recurrent pulmonary infections, recurrent Staph aureus infections. There will be characteristic facial features like there will be broad nose, and bony abnormalities like scoliosis will also be present. Now there is a concept between the anaphylactic versus the urticarial transfusion reactions. Anaphylactic reactions are listed here and urticarial are here. Mechanism: anti-IgA antibodies, IgG or IgE in the IgA deficient patients against the donor blood IgA. Onset is seconds to minutes. Findings include respiratory distress and wheezes, angioedema, hypotension, and hives. Treatment is immediate cessation of transfusion, epinephrine, antihistamine, oxygen fluid, and vasopressors. Urticarial: preformed recipient IgE antibodies against soluble allergens in the donated plasma. Onset is for hours. There will be hives and itching. Treatment is immediate cessation of transfusion, antihistamines. Resume the transfusion if the patient is otherwise asymptomatic. Standard immunization. So standard pediatric immunization in the United States are inactivated vaccines, polio, hepatitis A and influenza. Okay. Toxoid, diphtheria and tetanus. Live attenuated ones include rotavirus, measles, mumps, rubella, and varicella. Subunit or conjugate ones are hepatitis B, pertussis, Haemophilus influenza type B, pneumococcal, meningococcal, and human papillomavirus. Then what is D-type vaccine? It is a toxoid vaccine. It is a complex of 3 vaccines: diphtheria, tetanus, and pertussis. So the schedule: 5 doses given at the ages 2, 4, and 6 months, 5 to 18 months, and 4 to 6 years. So 3 doses at 2, 4, and 6 months, then 15 to 18 months, and then 4 to 6 years. Complications: they can be seizures. Note a contraindication if they are uncomplicated, that is short, less than 5 minutes, and self-limiting. Give future D-type according to the schedule. Only observe the patient in case of seizure occurs. Anaphylaxis: hold all the vaccines containing diphtheria, tetanus, or pertussis components if the child is having anaphylaxis to that. There can be seizures, right? Then secondly, anaphylaxis, unstable neurological disorders, infantile spasm and uncontrolled epilepsy, and encephalopathy, decreased level of consciousness and prolonged seizures. Give only diphtheria and tetanus toxoid without pertussis. And post-exposure antibiotic prophylaxis is required for close contacts for anyone with a pertussis within last 21 days. Then we have meningococcal vaccine. So the meningococcal vaccine is routinely administered at age 11 to 12. Children with asthenia, HIV or complement deficiency may be vaccinated as early as age 2 years. Otherwise, the meningococcal vaccine is administered at age 11 to 12 years. So this is all about the allergy and immunization. We'll continue with the central nervous system in the next session. Until then, Allah Hafiz, fi amanillah, and take care.